we've covered quite a few of these as we've been going along, but I'll just sort of start with the first one in terms of the access to data, and whether it is, whether the population health analytics will be carried out by a central group of analytical staff. So as Richard mentioned, there will be a very small sort of core team, but it isn't the intention that we will essentially be doing the actual sort of analytics. That's very much sort of at a whether that's at an ICS level, and we're having follow-up discussions sort of with them over the next few weeks. But the expectation is that will be sort of either local or ICS. I don't know whether you wanted to add to that, Richard, in terms of some of your discussions you've had with colleagues.
Yeah, so I think what we've been really keen to do is to talk to existing groups of specialists, and they're either in Trust BI departments, or you usually see quite a number of people in cities, in the councils, or in the CCGs. So we've been talking to them about how we can make available this capability. So those people that are already the specialists can get access to the data that they want. And what we're trying to do is to make sure we've got enough centrally to help and support people, particularly when they first get on board and they've got questions and queries about where they put the data and getting people the right access levels. So we'll retain a small central capability to sort that kind of thing out. We've also got a long-term contract with a couple of suppliers to be able to do kind of bug fixing, and also to be able to do small changes. So if people want to see an enhancement or perhaps a new piece of analytical software, then we've got the capability to put that in as well. So we do want to have that long-term support capability to help people, particularly as they're first on board, but as they come up with new things that they like to see on the platform and the solution.
That's great. Thanks very much. I think we've probably covered the next sort of couple. In terms of the overall sort of roadmap, we've covered. Richard sort of talked about, what our plans are for the next future. But John, I don't know whether you strategically just wanted to talk about sort of, where we see the auction number care record going over and the overall sort of roadmap over the next sort of few years.
I suppose the world is our oyster, really, isn't it, in terms of the strategic question. I think one thing we have discussed as a team is that keeping our delivery, keeping all our aspirations grounded in delivery at the moment, because the one thing we don't want to do is appear too boastful and make promises that we can't keep up with.
Yeah, I think.
Can I just say something a little bit?
Yeah, you do.
On the roadmap, one of the reasons we're keen to have these events is almost like as a preliminary before we have some more workshops with the ICSs. So the three that make up our region, the plan is to get together with a representative sample of analysts and PHM specialists in their region, and where the highest priorities are and how we can help them with their local aspirations. So the idea is to kind of be led by what organisations would like to do, and then be as supportive to their aims as we can. Yeah.
Okay. That's great. I wanted to just sort of move down to some of the sort of more technical elements. And Steve, if you're on the line, from we saw your very clear demonstration, but there's a couple of questions around what conformant data model would you like us to submit data in, and also a bit around normalizing data sources, and I wonder whether you'd be able to answer those from an integration architecture, system of systems component part, if that's possible.
Yes, absolutely. Yeah. So all of the data that the integration services uses comes from the system of systems, which is the regional shared care record, and that uses this FHIR standard as its language that it talks in. So FHIR, for those that aren't familiar with it, breaks down healthcare data into sort of what are called resources, which are a sort of a nice level of granularity, so not too big, not too small. So there are the administrative things like patients and encounters, and there are the clinical things like observations and conditions. And what we ask is that the providers into the shared care record map their data into these resources. And once they've done that, we can then assimilate them and we can treat them as equals. Now, it does go further, and we've got there's a data architecture design authority in the region, the DARDA, that is overseeing standardization of specific things. So, for example, if there was a particular way to represent a blood pressure or anything else, then we're going to go to the DARDA to lay that down and say this is how it must be normalized for the region. And when we do that, then those will flow through into the analytics platform, and then they can be compared and aggregated.
But just whilst on, do you mind if I ask a question, Steve? We've had a question from Roland from the Easter Coordinator about where we're making the code available. And whether or not we're putting it on GitHub so other people can have a look at it. And I think that's important for us because we are very much kind of keen on sort of open source and making available the assets that we've created. So I just wondered, Steve, if you could say something on that.
Yes, absolutely. So open source was a fundamental principle of the entire program. So we're adhering to that. There are already several assets available on GitHub. For example, we have made available a FHIR server, an FHIR server for use by anyone in the region. So this is somewhere where you can lodge your resources and it's all set up and ready to connect to the system of systems very easily. So some of our trusts and data providers have taken this open source asset that we've created and use it to store their resources. And eventually everything will go up there when it's in the correct state.
That's great. Thanks very much. So I'm conscious we've only got a couple of minutes left, but I wanted to sort of finish as we started with a question around sort of what and how will patients be able to see the details? How will patients be able to ensure data errors are corrected? So the population health management platform is very much for sort of health and care sort of workers. But the fundamental thing around sort of patients being able to see their data is very much at the sort of the front end, systems. So I mentioned sort of very briefly that we have the development of a patient health record helm that has been piloted in Leeds, and that was part of the program. But also, you know, patients do have much better access to their primary care records. You can see through various apps your online sort of record, but also sort of within your hospital systems, then actually working closely with clinicians to make sure that anything is reported sort of back. And I don't know, John, whether you just wanted to have a sort of final word around that sort of interaction with sort of patients and how we make sure that we keep the visibility and openness as much as possible.
Yeah. It's interesting, Monica. I think we believe this is a work in process. So even though we've done that sort of deep dive at the start, that wasn't the end point. And I think we just appreciate, A, we have to be visible with regard to the program. B, we need to keep talking about it, you know, because we're all citizens on this webinar, but we need to keep going with that external communication piece as well too, because if we don't, we'll lose credibility. But not just that, we also lose that opportunity, because I think for population health management to work, or integrated health and care records to work, or to integrated health and care plans to work, ultimately the public need to know they're available, that they're out there, because then they can start working with health and care professionals to trigger them to go and use the tools that we are providing. So actually, in order to make this program really be of benefit, we need the patients to be encouraging everyone to use it for their benefit.
That's great. Thanks very much, John. So we're out of time. I think we addressed quite a lot of the questions as we were going along. But if you do have any further questions, then you can get the information on our website. But also there's the email address, the generic mailbox there. And if you just send, no question is too daft, and please just send that through, and we will respond, very quickly, and I'll just give the final word to John.
So firstly, thank you for everyone for coming along to join us. Really grateful for the team to putting all of this work together, because I know a lot of work has gone on behind the scenes, particularly from Rebecca. So thank you, Rebecca. There's some great questions on the live event Q&A, which particularly a few have come in from Elaine Borthwick. Hopefully the answers that we've given you there are helpful. But look, I suppose the question for us is, when we do this all over again in the next 3 months, 6 months or 9 months, you'll be able to see the value of this, the user cases that are right there, and how this might actually make a difference for you in your job, or more importantly, the people that you serve every day. So thank you very much, everyone.